Good morning and welcome everybody to today's Coffee, Kids, and Sports Medicine. I'd like to thank you all for joining us both live and online. A couple of housekeeping items as usual. We'll talk a little bit about some of our previous talks here, the on-demand lectures. Some of these do expire, so if you have not seen them, please go ahead and log in and take a look. These are great talks and great resources. We hope you guys are getting a lot of information material from them. A couple things on our CMEs. If you tried to log in and get your CME earlier this morning, you may not have been able to. The link kind of is timed on, so about 5 minutes ago it timed on. If you attempted to do this earlier, it didn't work for you, go ahead and try again, and I think it'll work now. Two ways to do this. You can text the code here to the number. It'll link you into the site to claim these CMEs, or you can scan this QR code and enter that same code. We have nothing to declare in relation to today's talk. We're going to welcome Dr. William Morris today. Dr. Morris is a pediatric orthopedic surgeon here at Scottish Rite. He attended Case Western Reserve University Medical School, followed by a fellowship in child and young adult hip preservation at Boston Children's Hospital, and then eventually our pediatric orthopedic fellowship here at Texas Scottish Rite, where he is brought on his staff afterwards. He's going to talk to us a little bit about evaluating the newborn for DDH, and going to be a great talk today, and hope you guys really enjoy it. Go ahead and welcome Dr. Morris to the stage here.
All right, well, thanks everyone for joining and for the opportunity to speak today on evaluating developmental dysplasia of the hip in the newborn, an overview and exam demonstration. As Jared explained, I don't have anything to disclose relevant to this talk. We'll go through a couple of the learning objectives first. So, I think there's a couple of key points that I want to bring out in the lecture. After this activity, goals for having seen this talk would be to be able to understand the risk factors for DDH, when talking with pediatricians and family practice docs and other providers. There's certain changes that have happened over the past 10 years that I think we can kind of highlight, as well as the importance in terms of the timing and the rationale for when we send patients for screening studies. To describe the key elements of the infant hip exam, and this is one of the big points that we'll have emphasized, both in terms of a video with an infant, as well as then going back through with some key figures to illustrate what findings are reflective of developmental dysplasia of the hip. We'll also focus on some of the late presenting signs. So in a patient who's already ambulatory, what are some of the differences in how their exam presents, and what should raise flags if a patient's referred to you. We'll talk about anticipatory guidance for families, and hopefully I can encourage everyone to include healthy hip swaddling as part of that anticipatory guidance for new parents. And then lastly, we'll discuss the general treatment strategy and a bit of an algorithm for how we approach developmental dysplasia of the hip, and then discuss the success of non-operative treatment in infants, because there are going to be a number of times for you as providers where you're making that diagnosis of DDH, and to be armed with a little bit more information to reassure families that we're very successful non-operatively in treating this condition. In terms of the structure of the talk, we'll go through the definition of DDH, some of the epidemiology, including risk factors that informs who we think needs selective screening. There'll be a heavy emphasis on physical exam, as I already mentioned. We'll go through a little bit about imaging, what we're looking for, and how we make the diagnosis of DDH, and then finally our treatments, including prevention, and some take-home messages. So developmental dysplasia of the hip is characterized by a shallow socket or an undercovered femoral head. And it's a bit of a misnomer, because developmental dysplasia of the hip would suggest that there's a dysplasia or abnormal tissue as the underlying cause of the condition, but this is really more of a malformation, meaning that this was an anatomic structure that developed normal embryologically and then becomes malformed during gestation or perinatally. This can represent a broad spectrum of disease, all the way from physiologic immaturity, which is a term you'll hear me use a couple of times, which refers to a mildly abnormal hip that frequently normalizes on its own, all the way to hip that's subluxated or even frankly dislocated, as you can see with this left hip here on the x-ray. In terms of the actual incidence of developmental dysplasia of the hip, it's difficult to pin down precisely because it varies based on the geography of the study, how they're defining dysplasia, but it's generally thought to be about 1 to 2% of the population based on population studies. Interestingly, though, if you imaged all infants right on that first day of life or right when they're born, you'd see a much higher rate of sonographic dysplasia. And what that means is that a lot of those hips come out looking a little abnormal, and then over time they normalize such that by 6 or 8 weeks of age, we're down to about 1 to 2%. This is an important point because when we talk about screening later for something like breech history or family history, this is going to inform when we recommend getting those studies. If all comers for dysplasia is about 1 to 2%, the most severe form, or frank hip dislocation, is only about 1 in 1,000, so much less common. But towards the end of the talk, I'm going to show you information that shows how successful we are, even in that severe case, of treating them non-operatively. Referrals for DDH are about 4 to 5% of all births, either due to risk factors like breech or family history, or to an abnormal exam. And the rate that we actually treat is only about 4 to 5 out of 1,000. But we're very happy with that ratio because one of the recurring themes that we'll see is that this is a condition that is very successfully treated early if we make an early diagnosis, and very challenging and more complex when it's discovered later. In terms of the risk factors, the mnemonic that everyone learns in medical school are the 4 Fs, right? Female, feet first, family history, and being firstborn. Female sex is present in about 80% of cases, and firstborn birth order in about 60% of cases. A positive family history confers about a 12-fold increased risk, and that elevated risk is the reason why family history is considered one of the reasons for referral for evaluation or for screening imaging. And then being feet first or breech, this one's a bit unique in the literature because the literature's all over the place saying that the risk of DDH in a patient who's breech is anywhere from 2 up to almost 30%. Interestingly, the American Academy of Pediatrics originally didn't recommend screening for breech patients, but it's changed its tune over the past 10 years. And our study is one that reflects the reason why that stance on breech presentation has changed. More recent literature, including our publication from last year, shows that when you look at all babies who were referred for breech presentations, this is over 600 infants that were prospectively evaluated for breech history, and this is eliminating other risk factors, meaning someone who had a positive family history or who was referred in with an abnormal ultrasound. But those who came in with an isolated breech history, almost a quarter of them had some dysplasia or clinical instability on exam. And so that's consistent with a lot of the more recent studies, and part of the reason why any baby who's born breech or was breeching that 3rd trimester, we recommend screening imaging or referral. But what's also interesting, and just kind of illustrates the power of being in that breech position during the 3rd trimester, even with a normal initial screening ultrasound, our study demonstrated 2%. Other studies from Philly and from England demonstrate up to 7%. When you look at them later on with an X-ray, have some dysplasia. And what's likely happening there is that at that first screening ultrasound, you have a 2D picture of a 3D structure of that acetabulum, and it looks okay on that first picture, but we know that the hip is a kind of a moving target in terms of its development, and it's playing catch-up when the baby's been in that breech position. So certainly an important factor to trigger an evaluation. Finally, environmental factors are important. Now, developmental dysplasia of the hip is a multifactorial etiology, and so there's a genetic component. That's why female sex is a risk factor, so is family history. But there's also an environmental component that really impacts the rate of developmental dysplasia of the hip. And so this is this table here illustrates the vast differences in the rates of developmental dysplasia of the hip based on region. And this does reflect to some degree that there's a genetic component there, but really the take-home message of that table showing the vast difference in incidence is that how the babies were swaddled early in life really impacts how that hip develops. And there's a really neat study from Japan that came out about 20 years ago, actually my math is terrible, 40 years ago, on developmental dysplasia of the hip in infants in Japan. And what they saw is that in the 70s, they noticed that their rate of subluxation or dislocation of the hip was 30-fold higher than what we see in the US. And they tried to figure out what the difference was. And they realized that this swaddling diaper that they were using on the left here forces the hips into extension, a really unhealthy position for the development of the hip. And then right here with this vertical line, they had this national campaign to try to encourage healthy hip swaddling that allows the hips to flex and abduct, as you can see in the picture in the center. And the rates of subluxation, dislocation, dysplasia drop dramatically to be consistent with the rest of the world. So with all of that in mind, just to give you guys a picture of the updated clinical practice guidelines from 2016 in combination with the section on orthopedics and the American Academy of Pediatrics, the current considerations for referral or for imaging before 6 months of age are breech presentation in the third trimester. So this includes patients that may have been breech at some point during the third trimester and either had an external version or spontaneously switched to cephalic presentation. If at some point during third trimester they were breech, we recommend an evaluation regardless of sex. A positive family history, history of either previous clinical instability or other concern on exam, and then also a history of improper swaddling. Again, highlighting the dangers of forcing that hip into extension over time, that you can gradually negatively impact the development of the hip. A brief word of caution on hip click. So this is an interesting point because the literature may be swinging the pendulum in the opposite direction from the current guidelines. So the American Academy of Pediatrics doesn't currently recommend specifically screening for hip clicks. The thought is that these may just be kind of benign soft tissue clicks, which is probably what everyone is taught, in their training. But if you look through the literature, the rates of dysplasia associated with patients referred for hip click is all the way from just 2% up to almost 30%. So we looked at our prospective database of patients that had an isolated hip click, meaning no breech history, no family history. And of those over 250 patients, about a quarter of them had some sonographic abnormality. A lot of those resolved just with observation, but a pretty high percentage that had some abnormal ultrasound, and 5% of them had what we consider severe dysplasia. So this was presented this past year at the American Academy of Pediatrics, and getting ready to submit this for publication. So again, another piece of the puzzle to help try and swing the pendulum back towards more aggressive screening with hip clicks. And these findings are consistent with a recent publication from the International Hip Dysplasia Institute. This is a big multi-center research group on hip dysplasia that Scottish Rite's a part of. And what they found in their study is that of all of the dislocated hips that were coming into their clinics, when the surgeon was blinded and they examined the hips, 14% of those hips that were dislocated, we thought were stable on exam. So nobody's perfect. And obviously, for those of you who are sitting at home having your coffee, and those of you in the audience, you're examining just as many baby hips as I am, and even with all of that practice, what we may perceive as a benign kind of soft tissue click may be something a little more sinister. So we'd recommend some screening, imaging, or referral when you see those hip clicks. Again, I think if you have an infant who's upset, you're not going to get a good exam of the hips, because once those muscles tighten up, if they're crying or fussing, you're not going to be able to feel some of those subtle findings of instability, laxity, that might suggest that there's some dysplasia. We talk about all of these different exam findings, and overall you can think of this as of the spectrum of findings helping you fall into different categories, anywhere from a normal hip to a hip that's unstable and may have a little bit of increased laxity, but doesn't actually dislocate. A dislocatable hip, which rests in a reduced position but has instability, such that with that Barlow maneuver, which we'll look at one more time, you can see the hip dislocate, or feel the hip dislocate. A dislocated hip at rest, which you can then reduce into the socket, which would be an Ortolani positive hip. And then finally, a hip that's dislocated and can't be reduced, or a fixed dislocation. Again, the reason why we want to see all these babies early is that without treatment, a hip that's dislocated is going to eventually stiffen up and become a fixed dislocation. All of our treatments are much more successful when there's still that instability where the hip can slide back into the socket. So, as I mentioned before, these findings represent a spectrum from kind of the mild dysplasia, where you may see things like limited hip abduction or some slight asymmetry in the thigh folds, all the way to a frank dislocation, where you'll see things like a Galeazzi sign, where one leg appears to be shorter when the hips are flexed. Going back through one more time, our maneuvers, the Barlow maneuver is describing a hip that's reduced in the resting position, but then by bringing that hip towards midline with a posteriorly directed force, you can feel a clunk of that hip sliding out or dislocating. Although this hip is in a reduced position at rest, these hips can convert to a dislocated hip without treatment, and so even though it's in the socket, we treat all of these when we feel them. In contrast, an Ortolani positive hip is a dislocated hip at rest that can be manually reduced. And so, every infant is a different size and your hands may be different sizes. So you'll have to figure out what technique works best for you. But for me, that's putting my hands around the knees, as you can see on the top left of the picture, and then my long finger on the greater trochanter so that as you abduct the hip, you can provide an anteriorly directed force on the greater trochanter and hopefully feel it clunk in. Again, this reducibility is eventually lost as the muscles, capsule, things tighten up. And so early identification and treatment is paramount. Otherwise, what we anticipate happening over the first few months is that the hip is going to stiffen up and if it's dislocated, will eventually become a non-reducible hip or an Ortolani negative hip. So there, you're not going to feel a Barlow or Ortolani, but you will see some of the other stigma that the hip is dislocated, like asymmetric abduction, where the affected side can't abduct out as far. A Galeazzi sign, which we have a better picture of here. This is from a recent patient I took to the operating room, where when you flex the hips up, because that hip is dislocated, the femur is resting further posterior and the leg appears to be shorter. And then finally here, one more time just to illustrate the Klisic test, again for asymmetry, you can see that when you have a line from the greater trochanter to the palpable anterior superior iliac spine, in a dislocated hip, that line passes below the umbilicus, and in a normal hip should direct towards or above the umbilicus. So even if you have bilateral dislocations, you should still be able to use this test, unlike some of the others which rely on asymmetry for diagnosis. In older patients, let's say a patient's moved from another city, or they're transitioning providers and they're just meeting for the first time and they're already ambulatory, what are some of the unique signs that you may see that would suggest that you have a dislocation? Well, you may see increased lumbar lordosis, particularly with bilateral hip dislocations. So you see this exaggerated lordosis or sway back deformity, which is a compensatory stance when the hips are dislocated. And then you may also see a waddling gait, or individually, if it's just one side, a Trendelenburg gait. And what's happening here is normally when we stand on one leg, so like standing on this right leg, the reason why we're able to still stand straight is that our hip abductors, like this is glute medius, our hip abductors help us balance by pulling our body back over the top of that hip. When the hip's dislocated, it's at a mechanical disadvantage, so that muscle's a little too weak to help us balance. And so you see one of two things. The pelvis either drops away from the leg that you're standing on, or you may also see that the body leans over that leg to help try and center the body weight over that hip joint. So this is an example of a young lady who presented us at walking age for concern for limp. And so if you're seeing a patient for limb length difference, limp, as kind of the first line, don't forget about the hips, because this may be a sign that there's a late presenting hip dislocation. So you're going to see as she walks, she's leaning over that right side when she's standing on her right leg. And then when she's standing on her left, she's more powerful, and so she's able to stand normally, but she's leaning over the right each time she's standing on that right leg. And so when we got an x-ray, it unfortunately confirmed that she did have a right hip dislocation. So that was the reason why we were seeing that, because that hip was at a disadvantaged position and those muscles weren't strong enough to support her. And so she had to lean over as compensation towards the dislocated hip. So we have those clues clinically, but our diagnosis is still made with imaging. In younger patients less than 6 months of age, ultrasound is our workhorse. The purpose of the ultrasound as opposed to an x-ray is that the hip is primarily cartilaginous at this age, and so you can't really get a lot of information from x-ray. So this is how I like to orient the image, so I turn it more vertically so you can imagine it's almost as if the patient is standing in front of you. So here's the pelvis, socket, and then there's the femoral head, there's the ball. We look for a couple of things to help us illustrate how well the hip is covered. When we draw a vertical line down the pelvis, we want to see that more than half of the ball is covered by the socket. You can see here on the right we have a well-covered hip, and you can see more than half of the femoral head is tucked underneath the socket. Compared in the bottom middle, we have this dysplastic hip where only about a third of the hip is covered. We also look at the roof of the socket. You can imagine if you have a really steep roof, like we do in this dysplastic hip, it's hard for the ball to sneak underneath the roof of the socket, versus if we have a more horizontal roof, it can accommodate the ball within the socket better. We can measure this angle, this what's called the alpha angle, and looking for an angle greater than 60 degrees, although it didn't include numbers for the purposes of the talk here. but you can see the difference between the shallow hip with a more acute angle of the roof and the more horizontal roof in the well-developed hip. If a baby has a breech history or family history and we're getting a screening ultrasound, but they seem to have a stable exam, we usually wait until about 6 to 8 weeks of age to get that imaging. And again, the rationale when I talked to you before is that if you imaged all babies on week 1 of life, you're going to see a much higher rate of dysplasia that will be what we consider false positives because they're going to resolve by the time the patient's 6 to 8 weeks of age. Just to illustrate that, there was a nice study that came out of Turkey where they had over 400 patients that had, without getting into the weeds on classification, what we call mild dysplasia, so pretty mild sonographic abnormalities. And they were diagnosed before 6 weeks of age, so around 27 days. And then nothing was done for these kids once we diagnosed them with this mild dysplasia. They were just observed and brought back in 2 to 3 weeks. And 80% of them resolved spontaneously when they came back at that 6 to 8 week mark. And so if there's a concern about instability on exam, you think you feel a click or a clunk and you're not quite sure, then referral or getting the imaging study is really the right way to go because you'd much rather start treating a dislocation early. But if we just see these mild findings, we end up just observing them anyway. And so if a patient's being referred for just a risk factor with a good stable exam, then we generally wait until 6 to 8 weeks to get that study. In patients who are a little bit older, and generally this switch happens at around 6 months of age, but is a little surgeon dependent, we transition to an AP X-ray to evaluate the developing hip. At this point, there's been enough ossification that we can start to see more of the structure of the femoral head and the acetabulum. And so you can still see here that whether the ball is located in the socket, so you can see the left hip is reduced, and here this is a dislocated right hip. And we can also start to evaluate the shape of the acetabulum. So we can look at how steep or horizontal the roof is. And we'll come back at the very end of the talk to look at how we can chart that and monitor it the same way that y'all look at height chart, weight chart to determine development. Once you've made the diagnosis of dysplasia, we'll go now through kind of what our treatment algorithm is. For all of our kids under 6 months of age, our first treatment is going to be a Pavlik harness. And the way that this works is a series of soft straps that generally holds the hips in flexion and abduction. And this was revolutionary back when it was first created because the previous braces were rigid and held the hips into forced abduction and carried a risk of things like avascular necrosis or limiting the blood supply to the femoral head because they forced that hip into abduction and compressed the blood vessels. This brace is soft, dynamic. It allows the hips to move around and is quite comfortable for kids. And so this avoids that risk, as long as it's tensioned appropriately, avoids that risk of avascular necrosis generally, and then is tolerated very well by infants. It's generally worn for about 6 to 12 weeks, and there's a number of factors that go into exactly how long it's worn, but just to give you an idea of the timeline, and it's worn full time. So this is gonna be a big part of this infant's life. So you can see families will make it their own, they'll diet. I've had kids, coming in with bedazzled Pavlik harnesses. So, the family really takes to it well and the kids do well with it, but it's an incredibly successful treatment. Now, as providers, one of the things that y'all may hear about is what do we really want to watch for? If you get a call about this, what should you be concerned about? And I'd say the big thing that we're watching for and we counsel families on is the importance of watching for femoral nerve function. So remember, that's what powers the quads and creates active knee extension. So every time we're seeing patients in clinic, and we generally see them every 2-3 weeks, kind of depending on where they are in the treatment process, we're taking that harness off so that we can look and make sure they have active knee extension. Because what we know can happen is with the hips flexed up, it can create some compression on the femoral nerve and can create a temporary neuropraxia or put it to sleep. We published a study on this. This is before my time, 11 years ago. And what it showed is that the rate of this occurrence was about 2%. So not super common, but it's really important to identify. Most of them occur, almost 90%, in that first week that the harness is on. And then what's also important here is that the occurrence of this is associated with decreased success of Pavlik harness treatment. It tends to be the most severe cases, so the dislocated hips, not the mild dysplasia where this occurs. But once we identify it, we want to get the harness off. And so if you all get a call about this, this is something that we need to know about immediately too. And so encourage the families please to notify us. And what we'll do is we have them take the harness off. let the nerve wake up, and then reapply it. And it's important to identify it early because as soon as we know we want to let the nerve rest so it can wake up, the faster we can get the harness back on, the more likely we are to be successful with our treatment. And we are very successful with treatment. I think this is another important take-home point because, for those of you who do get the ultrasound yourselves to screen rather than referring the patient in, sometimes you're the ones making the diagnosis and counseling families and having, handed out many tissues in clinic. I know this is very stressful for new parents when you're making this diagnosis. But even in the most severe cases, we're very successful non-operatively. So this is a study from one of my partners, Harry Kim, looking at almost 75 Ortolani positive hips, right? So hips that are resting dislocated but can be manually reduced. And the success in the pelvic harness is over 90%. So over 90% of the patients were avoiding going to the operating room. He also published a study looking at the Barlow positive hips, so the ones that are unstable where you can slide the hip in and out. And again, the success of getting the hip stable and reduced is almost 100%. So we're very, very successful in these, even in the most severe cases of getting the hips reduced. One key point though, if you look at this, the mean age of presentation is about 2 weeks and about 3 weeks. So early identification, early treatment is another key to success. It's not specifically evaluated with this study, but we know from other studies, the faster we see the patients, the more likely we are to succeed in non-operative management. If the pelvic harness fails to get the hip reduced, we still have other tools in our toolkit. The hip abduction brace, these are a bunch of different examples. We use something that's probably closest to what we see on the top left. Allows the hips to flex and separate, and it looks a little more rigid, but there's still some wiggle room, so it's still not the old versions of those braces that were very rigid and forced. But it again holds the hips in the same flexed and abducted position that gently encourages the ball into the socket and can be successful for us, and without diving into the literature, is usually patients under 6 months of age where the hip still feels reducible. So again, another reason why it's important to see them early. What if we can't get the hip in non-operatively? Well, just to describe a little bit about what we do for our patients, in case this is something that you're wanting to learn more about or hearing about when you make that diagnosis with a family. Generally, what we do and how I counsel patients is that the first step is to provide anesthesia so that all of those muscles that have become contracted over the first 6 months, we usually wait until about 6 months of age to decrease anesthetic risk, have a chance to relax with anesthesia. And then frequently, when we try to manipulate the hip, we can reduce it manually. After we can feel the hip is reduced, if it seems stable, our next step is to see, is the ball appropriately positioned in the socket? And so to do that, we perform an arthrogram. A lot of times with these young hips, you saw that we can start to see some of the shape of the hip with the x-ray, but we can't see all of the cartilage of the socket and the ball that's not yet developed. And so we perform an arthrogram. It shows us whether the hip's in an appropriate position. And we can get a lot of information from this. So we put dye inside the joint, and you can see the dye is this dark fluid here within the hip joint. And it can show us where is the ball positioned within the socket, the shape of the ball, the shape of the cartilage of the socket, including the labrum that rings the socket. And all of this can give us a good detail about whether or not we're able to create a stable reduction that's in a good position. If we can't get the hip well reduced, or we can't feel it move into the socket when we try and manipulate it, the next step is to perform an open reduction. That's where we actually make an incision to clear out the obstacles that are blocking the ball from getting into the socket. And then we confirm either with manipulation and an arthrogram or by opening the hip up that we have the hip in a good position. And then the last step is to apply a spica cast. And this is a cast that then maintains that well-reduced position for anywhere from kind of 6 weeks up to 4 months, depending on a number of different factors related to age and what was done for the patient, but can help stabilize the hip. After this, the cast helps maintain that while the hip matures in that position, and then eventually the cast is removed. So this patient I showed you initially who came in with a limp was found to have this right hip dislocation. And this is an example of an x-ray with the patient after doing an open reduction where the hip's well reduced. And this is going to help maintain that hip in a stable position as it heals. The last thing I wanted to touch on related to dysplasia before we talk about prevention is some of the sequelae. So I've received questions from pediatricians about, well, once we get the hip reduced, are we done? And in patients where we actually treat them for dysplasia, particularly the patients where we take them to the operating room for either a closed or open reduction, this is somebody that I'm going to watch as they grow up and get on the high school soccer team and are even going to college, because we know there's a high percentage of these kids that need something else from us in the future. So two of the most common sequelae from this condition include what's called a proximal growth disturbance. So something about putting the ball into the socket seems to affect the way the ball grows. And so this is a pretty pronounced example of this, but sometimes it can be very minor things about kind of the shape of the hip. The ball can be a little large or a little small. So it doesn't necessarily affect function, but is very common. And then probably the more important and more common is residual dysplasia. So as I showed you on that previous x-ray, the dislocated hip, the socket was very shallow because it hasn't had the stimulus of having the ball in the socket to continue to develop well. And so when we put the ball back in the socket, there's this kind of 18 to 24 month period where the hip is catching up and the socket's becoming deeper, better covering the ball. But we still see that there's a significant percentage, whether we make an incision or not, where the socket's still shallow a few years later or when they're teenagers, and something else needs to be done to try and encourage the hip to be well covered. So a couple of years ago, I looked back at 40 years of experience from Scottish Rite and looked at all of the kids who had either a closed or open reduction to try and answer this question of how often are we coming back and intervening again, and how often is the socket still shallow as they get a little bit older. So we looked at about 150 kids that had either that had a dislocated hip that either underwent a closed reduction, meaning manipulation, or an open reduction, which actually opened up the hip joint. And the groups initially were relatively similar in terms of their age and gender distribution. But I think the important take-home points for this were, one, that there's a very high rate of some subsequent surgery for residual dysplasia for the socket still being shallow. Whether we do a closed or an open reduction, if we're getting to them before 12 months of age, it's about 30%. And again, not to keep coming back to the same point, but if you're seeing a patient and we're getting to them to the operating room late, meaning over 12 months of age, particularly if we do a closed reduction, over 50% of those kids are having some other surgery later to try to improve the shape of the socket to better cover the ball. So again, another reason why it's important for us to meet these kids early. Our treatments are more successful when they're younger, non-operatively, and then even if we go to the operating room, the earlier we get to them, the less likely they are to have some subsequent surgery. After we've gotten the hip in the socket, the way that we follow these kids, and I alluded to this before, is with our own version of this is our orthopedic growth chart. So we do also look at height and weight, but we can measure the development of the hip using this angle called the acetabular index. And this isn't something that I'm expecting anybody to measure and chart on their own, but just to illustrate for you, it shows you the roof of the socket relative to a horizontal line. And you can imagine if the socket was really shallow, that angle would be very big. And the better covered the hip, the smaller that angle is as it closes down over the top of the ball. And so unlike the height chart and the weight chart that go up as you get older, this angle should get smaller, so hip coverage improves over time. Most of our kids with a dislocated hip are starting out up here off the chart, and then once the hip is reduced, they tend to come down onto the growth curve. But we can monitor them and see, and this is something that I'll do with families in the clinic is counsel them. I can plot this out and we can see, are they floating off of the curve or dropping onto the curve, and make a decision about whether or not they are a good candidate for a subsequent surgery. So for the last few minutes of the talk, I wanted to touch on prevention, and it's certainly worth a pound of cure in developmental dysplasia of the hip. This is one area that I would really encourage all of you to incorporate into your anticipatory guidance with families, because we know how impactful healthy hip swaddling is on the early development of the acetabulum. So again, the key principle with hip swaddling is to avoid forced hip extension. So when we look back at that Japanese study that showed the, kind of more of a papoose style where the hips are extended, we know that that can cause a tremendous increase in dysplasia. And so we want to make sure that we allow the hips to flex and abduct. Sleep sacks are great, and they're certainly, it seems like, more and more common, and have that capacious area by the legs that allows the hips to flex and separate. But if you're swaddling, it's important to perform healthy hip swaddling. We have a video on the next slide that'll be available as a resource that you can also pass on to families that illustrates avoiding tight swaddling around the hips. Finally, with baby carriers, you want to make sure, again, that they're sitting in an M position. It's usually either facing against parent's tummy or facing outward. And you want to have a broad support under the hips there so that the hips are flexed and separated as opposed to dangling in extension. So we also have a video on proper swaddling technique. And again, at the end, I'll have a couple QR codes that we'll make available online too that you can also direct families to. But I think this is a very valuable thing to incorporate as your anticipatory guidance to try and reduce the rates of dysplasia. One of the other really important topics to discuss is that of healthy hip swaddling. We know that the position that babies' hips are held in infancy can have a dramatic impact on that early hip development. And so Kristen's going to illustrate how to properly swaddle babies' hips so that we can ensure that they're not in forced hip extension, which we know is a position that can encourage the development of dysplasia during infancy. So as you can see, Kristen is doing a nice job of snuggling those arms in tightly with the proximal aspect of the swaddle, the part that's going around the chest and arms. And it's okay for this to be a little bit more snug, which infants frequently prefer. But after swaddling the arms, one thing that's very important to do is to ensure that there's adequate room for those hips to flex up. As you can see with Kristen opening the swaddle, there's abundant room by the legs to allow her to flex her hips up and keep them in that healthy position. And so educating families on the importance of healthy hip swaddling and avoiding that forced hip extension can certainly do a lot of good in preventing dysplasia in infants. All right, so for our final take-home messages, again, risk factors for DDH: female, firstborn, feet first or breech position and family history. And then I really encourage you guys to have a low threshold if you perceive a hip click to consider screening, because there's growing evidence that it may represent something a little more sinister than just a soft tissue click. Refer patients early and often because we can see it every step along the way. The earlier we see these patients, the more successful we are in treating them, whether it's operative or non-operative. And non-operative treatment is very successful. So if you're counseling families, if you've obtained the screening ultrasound, you've diagnosed them with dysplasia, and you're referring them to see us, I'm having experienced this many times with family. There's going to be a very stressful period before they come to that first clinic visit, and the more reassurance you can give the family that even with a hip dislocation, we're very likely to be successful with non-operative treatment, I think will be really appreciated by the families. And then encouraging healthy hip swaddling, adding that to your anticipatory guidance can do a world of good in preventing this condition. These are the QR codes for the infant hip exam and for the safe swaddling technique that we're going to make available for everybody for online reference. I just want to thank everyone for your attention. I look forward to taking some questions. That's a great question, and my guess would be one of the questions online is someone's going to ask about transverse lie, because we get that question a lot too, as opposed to being, frankly, breached if the baby's transverse. The thought process is that as the hip is developing and space gets tight within the uterus, that being breached forces the hip into a position where it can't develop well, and that's the dysplasia, that's the malformation that we talked about. So this is really, it's considered a risk factor if it's during the third trimester, because otherwise, the baby's flipping back and forth over and over again, and it's not tight in the womb in those early trimesters. But in that third trimester, that's where we think it carries a risk. And then to preempt what may be a question online, there's not necessarily literature about transverse lie, but and another question we frequently get is, well, how long do you need to be breached? What if it's during third trimester, but then at 34 weeks they convert? Does that carry a risk? And there's no literature, to my knowledge, that looks at exactly what the dose is of being breached that confers that risk. But I think the most important point, and it's the same thing for hip clicks. If you have a concern, there's no radiation to an ultrasound. There's some cost, but I think the cost to the patient of a missed dislocation or untreated dysplasia is so high that if the patient was breached during third trimester, even if they're a transverse lie, it's not unreasonable to get an ultrasound so that you have, it's better to get the ultrasound and know that you have healthy hips or the information so you can refer them for evaluation, observation, or treatment than to say, oh, well, they were only they were only breached for the first few weeks of third trimester, or they were transverse lie, and we don't have good literature on that. It's always safer to go ahead, and we're always happy to see patients, even if it's just a parental concern, but it's always better to get the ultrasound or to refer them down so that we can make sure there's nothing more sinister there. Yes, I think if they're told that they were, if they were told they were in the breech position in the second trimester and it was very clear when the timing was and not in the third trimester, then our literature would suggest that that's not the increased risk. And the AAP guidelines are that that's not the increased risk. If there's a question, there's some uncertainty, or if at any point during the third trimester the baby was in the breech position, go ahead and refer or get the screening imaging. Sure. So, so as far as ultrasound in general, we prefer ultrasound up until about 6 months of age. Excuse me. It's a little bit variable. So I have some partners who will continue to get an ultrasound a little bit beyond 6 months of age, but the idea is that after about 6 months, the hip has matured enough in terms of ossification of the hip that you can get good information from an X-ray. And then less than 6 months of age is for pretty much everyone is going to be an ultrasound. So that's the gold standard in younger patients. And then the other point again is if this is a screening ultrasound with a stable exam for a breech baby or for family history, we usually wait until about 6 to 8 weeks of age to reduce the false positive rate. I personally get an ultrasound at 6 weeks and then I get an X-ray at 6 months because there's other studies that show if there's dysplasia at 6 months based on X-ray measurement, then there's a treatment that I can use at that age using one of those abduction braces to improve the hip. I have other partners that would rely on ultrasound and wouldn't necessarily get X-ray, but I'm making that decision based on the evidence and what I can do with it. So I think that you start to go down the rabbit hole a little bit of kind of what's more cutting edge in terms of surveillance of the hips. And so if somebody's getting the imaging, and they want to screen the patient, I think that getting that first study around 6 to 8 weeks of age is what's appropriate. And then as far as surveillance, I usually see the patient at 6 months, then 2 years of age to try and catch that 2 to 7% that end up with late dysplasia to make sure we don't miss those. And so in general, I would just encourage you to refer the patient so that we can follow them for that first 2 years and make sure they don't end up with a late presenting dysplasia. But I would say otherwise, at least that 6 to 8 week mark for the first screening ultrasound is what's appropriate. So that's a great point, and thank you for the question. I think that illustrates a group that we're worried more about the stability of the hip, right? If you think it's subluxatable, and certainly there's a lot of infants that, that they still have, relaxin is the hormone that's coursing around from mom's blood and baby's blood when they're first born. So there's going to be some hips that when you see them you're doing your newborn nursery rounds, that it feels a little lax. And then by the time they come to see us a week or two later, doesn't necessarily feel lax. But I would say either getting that screening ultrasound early to make sure it's not a dislocated hip or referring over is appropriate because there you're worried about stability. If it was, again, just a risk factor being breech or family history, and the hips feel stable, in those kids you're worried about, not worried about false positive, but I prefer to wait to 6 to 8 weeks to reduce the false positive rate. But if I have any concerns about stability or a click, is this a click or is this a clunk in such a little hip, I will get an ultrasound immediately because if I identify the dislocated hip, that's not one you observe. If you identify a very severe dysplasia or dislocated hip, you treat at a younger age before 6 weeks. Yeah, that's a great question, and I don't know that has been evaluated in the literature to say, for example, okay, baby was 32 weeks, so should we wait until 46 weeks to get our screening ultrasound because there's a positive family history. I don't know that I have specific guidance for that. In general, if the baby was early, I might lean closer towards 8 weeks to get the study as opposed to 6 weeks. I think, and again, that's assuming you have a stable exam. Ultimately, it's probably reasonable to still get it 6 to 8 weeks of age, even if they're a little premature. Part of why we wait is because of the maternal hormones that are coursing around in the baby's body, which would be cleared out by then. Some of it is the development of the hip, which will be a little lag behind. But if the hip feels stable and you get that screening ultrasound, if it's mildly dysplastic, then I'm just going to observe the patient anyway. And if you're getting that screening ultrasound at home and you or not at home, at work, and you see that there's some dysplasia, you're going to refer the patient down, and then by the time they see us, we can make the decision about whether or not there's still residual dysplasia, if the hip was just a little immature, which is what you're suggesting with the premature baby, and whether or not to treat or to continue observation. In general, we think of conditions that decrease the space in the womb as being associated with dysplasia, but it's not necessarily a hard and fast, risk factor that you have to treat, like oligohydramnios, for example, which would be the same sort of principle, right? Things are a little tighter. And so, I think that there's other factors which play a role, but by themselves are not an absolute requirement to screen. But in general, these are things that decrease the space in the womb that we think kind of affect the position of the hip, may put it in an abnormal position and increase the risk.
Got it.
But I think you'd have to combine that with your physical exam, and if you notice things like asymmetric bifolds or some limited abduction, or if there's any other piece of the puzzle that might trigger you to get an ultrasound. And then again, I think ultimately, if you have a concern, if it's in the back of your mind, it's always better to go ahead and get the ultrasound because there's no radiation involved. You have that reassurance, and then that subtle exam finding, maybe associated with some small risk factor, you have the answer, and then you can rest assured. Well, I think that's a credit to the audience, is that y'all do a wonderful job of screening infants in newborn nursery, and then come back, and sometimes who's seeing them in the nursery is different from who's seeing them at 2 weeks. But all of the physicians and providers here in the audience and online do such a great job that we're usually meeting these kids early, and that's the whole purpose of guidelines on screening and who is at risk, is to try to reduce that rate of kids that come in when they're already walking age, or after 6 months, where we kind of lost that ability to reduce the hip with just the Pavlik harness. And so thankfully, we're usually meeting these kids in the first few months of life. So if the referral is or imaging is just for a risk factor with a stable exam, I'd recommend waiting to 6 to 8 weeks. So that's specifically, the big ones are going to